Our thoughts towards sleep. I am going to review kind of 3 areas that come up most often with parents and teams that surround children. Please feel free to send in questions as we talk, and I know Coffee will do a great job organizing those. I'll also try to respond to any questions that we don't have time to do out loud by looking through the questions later and typing a response. You can also email me with questions if I miss it today, or you think of a question later. So, pediatric sleep, normal or not, and what to do about it. Our objectives today, after participating, is that we should be able to define and review with parents and kids what target total sleep times and circadian rhythms are at the different stages from birth through teen years. Knowing really well what the range of normal sleep across the pediatric population is allows us to recognize what is not within normal limits. So the world of pediatric sleep is vast and there's so much going on, but it would be impossible for everyone to have a thorough understanding of this specialty area when their specialty area might be something different. However, a great place to start is knowing firmly what's normal and then being able to tell a parent, well, I don't know what this is, but I'm concerned that this is outside typical range because I understand typical range. And so we should work further on this topic. The second objective is to express why diagnosing OSA in toddlers to teens is important and use a screening tool, implement at-home testing, and then guide next steps. And then our final piece will be looking at prescribing practical solutions for insomnia, specifically in kids who have autism. So to go to our first topic about total sleep time and circadian rhythm, I'll define these a little bit more. So in sleep, broadly speaking, we can usually look at 2 main areas of sleep, which is total sleep time and circadian rhythm. And those are broadly like the 2 main categories what we think about when we're trying to decide, is this child sleeping normally or not? So when we consider total sleep time, we're saying the amount of time asleep over a 24-hour period. Did the child get 8 hours of sleep? Did they get 13 hours of sleep? How much total time are they sleeping? Their circadian rhythm is when on the clock is sleep happening. Did they sleep 10 hours starting at 10 a.m. or did they sleep 10 hours starting at 7 p.m.? And so looking at both of those things is really important. The American Academy of Sleep Medicine has total sleep times recommended for each age group. And I will say, broadly speaking, anytime I've brought these up with parents, they can kind of say, yeah, my kid's probably not getting that much sleep, or they're at the lower end of that range. I'm talking with folks and parents who have sleep issues. So I'm sure there's plenty of children out there who are getting very good sleep. I appreciated that when our son started school, and they had like the starting school parent talk. The one thing I really noticed is they talked about sleep. And they said, we noticed your children do their best if they have been well rested. So please be mindful of getting them to bed early enough so they can get enough school before the start of the school day. So a child who's 4 to 12 months old should be getting somewhere between 12 and 16 hours. A child who is 1 to 2 years old should be getting 11 to 14 hours. A child that's 3 to 5 should be getting 10 to 13 hours. A child that's 6 to 12 should be getting 9 to 12 hours of sleep. And a teenager, 13 to 18, should be getting 8 to 10 hours. And oftentimes, especially teenagers, are not getting that range. And if they're saying that they're sleepy and they're getting 8 hours of sleep, I usually ask them to trial out getting 9 to 10 hours of sleep, and then we'll continue our discussion, because they may be getting 8 to 10 and you'd say, okay, that's in normal range, but maybe for that child, that teen, they actually need closer to 10. And I would want to know how they feel and what the differences are on 10 hours versus 8 hours. So circadian rhythm, there is a lot of interesting evidence for circadian rhythm across the ages. There is evidence for rhythms in utero, and I like this kind of visual. When we're thinking about why there's rhythms for baby in utero, there's a couple of factors. There's the maternal clock that's sending signals and keeping time. The placenta actually has a clock as well, and it changes what is being transmitted to the baby and what its kind of energy level is or metabolism. So there's a rhythm there that the baby is experiencing. And then the embryo also has a clock based on their own signaling and their own receptors. So there's a lot going on there, and there's a lot to say about in utero rhythms and activity. From birth to 2 months of age, I feel like babies actually take a step back when it comes to rhythms because they no longer have the maternal clock, they no longer have the placental clock, and they're just relying on their own clock, and it's not as well developed as it will be in the future. So from birth to 2 months of age, there are very few circadian markers actually. At about 2 months of age, melatonin and cortisol start to have more clear patterns, and babies start to have more body temperature variations, which is a clear signal of body clock work. In general, across all ages, and so babies starting at 2 months of age, their primary circadian rhythm drivers are going to be light and melatonin. So in sleep medicine, we call this a Zeitgeber. Light is the primary Zeitgeber, which means time giver, and it impacts the alignment and the entrainment of the circadian rhythm most strongly. Melatonin is the other primary time giver, but actually, interestingly, even melatonin is very tied to light, and it's usually as the light reduces, there's dim light melatonin onset. So it's almost like it is its own timekeeper, but it also is influenced by the primary timekeeper of light. Sometimes we need to investigate more what the circadian rhythm is for a child, and there is a children's chronotype questionnaire that helps determine and kind of tries to say, you know, is the child an early bird or a night owl, which can be helpful with sleep problems. So in infancy, in toddlerhood, so a baby 0 to 6 weeks old, their wake and sleep patterns are pretty much randomly distributed. 6 to 8 weeks old, the longest sleep period is more likely to occur at night, and babies start to produce melatonin and respond to light and activity entrainment. So they wake, feed, play, cuddle, sleep, repeat. Or if you do wake, cuddle, play, feed, sleep, repeat, they're going to pick up on whatever pattern is there. So it's helpful if you're mindful about the pattern and consistent. It's not just random, and what you're doing is intentional, because whatever baby does right before going to sleep, baby will start to entrain and understand that's a sleep cue. At 4 months old, the longest wake period is more likely to occur during the day. At 5 months old, babies can sleep a consolidated 5-hour stretch or longer. Oftentimes babies are sleeping more, but that's kind of the minimum. So if I see a 5-month-old baby who's still just sleeping 90 minutes at a time, I know there's something out of the ordinary there, and we need to work on strengthening cues, understanding what else is going on, moving forward and looking at that, because at 5 months old, babies and parents should be getting 5 hours of stretch of the sleep. At 6 months old, the longest sleep time clearly starts to follow the longest awake period. At 6 to 12 month old, the circadian rhythm is established, and babies should have consolidated wake periods and consolidated sleep periods. For toddlers, they should have distinct daytime naps and consolidated sleep period at night. I know this is a difficult time for parents because caretakers are always thinking about, like I'm kind of chained to the nap schedule. And it's tough because you do want to be flexible enough that you can go about your day and do activities, but you also have to be mindful about a schedule, and you're going to have a fussy toddler if you don't keep in mind their sleep needs. In early childhood, from 3 to 5 years old, there's gradual extinction of daytime naps, and there's consolidated sleep at night. And the child should be getting 10 to 13 hours of sleep. I would say a lot of parents will notice As their activity level begins, say they do pre-K at 4 or kindergarten at 5, their child may be more sleepy, and that's normal. But in general, there should be a trend of gradual extinction of daytime naps. In 6 to 12 years old, there's a tendency to sleep during the day. The tendency to sleep during the day is at the lifetime lowest. So I think this is very important to recognize as part of normal sleep. On average, normal sleep for a child 6 to 12 years old means they are not napping during the day. They can have irregular or occasional naps. Those are within normal range, especially if they're paying back sleep debt. But routine daytime napping may indicate an abnormal process causing excessive daytime sleepiness. And we'll talk a little bit more about one of the options there, but it's really alarming if a 6 to 12-year-old is regularly napping during recess, every day at school, or first thing when they get home, or they have to take an evening nap or essentially go to bed much, much earlier. So they're taking a nap before their typical bedtime. If there's routine napping in a 6 to 12-year-old, that should really put up a red flag. So circadian rhythms and total sleep time in adolescence. This is something that I feel like some folks know really well, and then other folks are unaware of, and it creates a little bit of disagreement between parents and teens. So teens are delayed phase. Adolescents are delayed phase. It is not a sense of like, oh, you stayed up too late watching YouTube or out with your friends, or you want to sleep until 10 and you're wasting the day away. They truly biologically are delayed. And this kind of shows us here on the side, if we look at core body temperature, melatonin, and cortisol, the patterns really change. So in childhood, we're going to expect to see that melatonin spiking, their body temperature dropping as they're getting ready for bed at what we would consider like a reasonable time, maybe 7, 8 p.m. And then their cortisol is spiking in the morning around 7 a.m. So they're in that kind of like 7 p to 7 a window with some variation. Adults are similar, maybe a little bit later. So they're more in the like 9 to 10 p.m. to 6 a.m. window, and they don't need as much sleep in general. But adolescents are more delayed than any other stage of life. So it's typical for them not to really be ready for bed until midnight, and not be ready to wake up until 9 a.m. And that is tough because our society doesn't run on a midnight to 9 a.m. sleep schedule. So a lot of times they're still going to bed late at midnight or later, but they're having to get up early, say 7 a.m. And that's just not enough sleep. So I try to encourage parents who have a significantly delayed phase child who really needs their sleep to encourage any time that there's an opportunity for a later school start time or sleeping in on the weekend, or if it's a persistent issue, then we have to do some entrainment with artificial melatonin a few hours before bedtime and bright light therapy, like at 6 a.m. in the morning when you're trying to train the brain to shift that delayed phase back to an earlier time. The heavy sleep inertia that comes along with trying to wake up at a time that's not typical is a really big issue for teenagers. And I have a lot of parents who will say, it is an everyday argument, and this is how we start our day. I have to be like, hey, are you awake? 4 times. And then I have to say, put your feet on the floor. Okay, stand up, walk. And then I'll find them asleep, like on a chair or a couch. And I'm like, you need to get out the door. And it's just like a battle back and forth. I usually say, okay, this is a heavy sleep inertia. We need to shift the schedule if at all possible, or we need to maybe talk about what can help shift the circadian rhythm. But also there are some kind of in-between things if it's not that bad. One I particularly like is called Alarmy. It's an app that goes on the phone. And it allows you to set up to 3 missions when the alarm goes off to be able to turn it off. So the alarm is exceptionally loud. And then when the sleepy person gets their phone and tries to turn off the alarm, you cannot push a button to turn it off. You have to do what you set up as a mission. And so the mission might be multiplication tables and doing math problems. It might be exercise. It has to watch you do jumping jacks, or it can be like take a photo of a kitchen sink. So that's really nice because it's essentially substituting in that parent role, but it's a AI version of it, and you don't have to get in an argument with it. It just will not shut off until they're up and moving, which is really helpful. And then it's just nice to shift that away from parent responsibility. And I usually tell teenagers, like, hey, you're 15, you're 17, that's not your parents' responsibility to make sure you're up for the day. And just say, you can't really argue with them because they're taking on a responsibility you should be doing yourself. And I tell the parents, you should just back away. It's not worth arguing about. Let them figure it out. Now, some parents will agree with that and it'll go how it'll go. Other parents will say like, no, because I know they just won't go to school and I can't do that, which is reasonable too. But I try to start that conversation of alternative options. So this is kind of a summary review of total sleep time and circadian rhythm across the ages as like kind of one visual diagram. So this is looking at an analog 24-hour clock. So we're starting at like using military time. So like this would be 6 a.m. up to noon, 2 p.m., 6 p.m., 8 p.m., 11 p.m., midnight, 1, 2, 3, 4 a.m. And when we look at the baby versus the child versus the teen, they are a lot different. So generally after babies maybe closer to 4 months of age, it's going to look like this, where there's still naps randomly throughout the day, but there's less awake time and more sleep time through the night, although there still are wake up times. The child should look like this, where they're fairly consolidated. No daytime napping, that would be abnormal, but there is good solid nighttime napping or nighttime sleeping that's also consolidated. And then teens have a shorter window of sleep, a shorter total sleep time of 8 to 10 hours, but it is shifted and commonly shifted where they're not going to bed until midnight or 1 a.m. Plenty are not even going to bed till 2 to 4 a.m., but past midnight is common, and then sleeping until 10 a.m. is common. So we reviewed the first objective, and now we're moving on to expressing why diagnosing OSA in toddlers to teens is important, a screening tool, implementing at-home testing, and guiding next steps. This is a huge topic, but I want to try to briefly touch on each of these points so that way we have like a bird's eye view and understanding and kind of consideration for next pieces. So why it is important. The importance of OSA can not be overstated. There are so many studies showing untreated obstructive sleep apnea leads to worse ADHD symptoms, disruptive behaviors, poor growth, and even failure to thrive, especially in infants and young children. And I have seen that prior in our pediatric sleep clinic, where a young child who has sleep apnea will have significant growth issues if it's severe sleep apnea that's not treated. It can contribute to hypertension. It can further contribute to weight gain due to hormone dysregulation that directly comes from untreated sleep apnea. It can cause altered cardiac morphology, primarily with right and left ventricular hypertrophy. Can contribute to pulmonary hypertension, speech difficulties, learning disorders, academic difficulty, enuresis or nighttime bedwetting, headaches, mood dysregulation, and anxiety. Enuresis is one where we're all taught once a child is night trained, if they go back to having bedwetting at night, we should be very concerned that something's going on. And on the list of other things you should be screening for and thinking about, keep OSA on there, because if they have OSA, that could be a reason why they have bedwetting. So screening tool, it's essentially you. There are several tools out there. I don't think they're excellent. And there's kind of a general guideline that I think is easier than knowing which screening tool to do. So think about roughly 5% of typically developing children will have obstructive sleep apnea. It'll be much higher in other populations, and I'll talk about that. But you kind of have to have a suspicion for obstructive sleep apnea and then a low threshold to evaluate. If you have a clinical history or a physical exam finding or social issue that kind of makes you think like, I wonder, essentially, if you say, I wonder, you should probably refer them for further evaluation and testing. So in their clinical history, if they snore, have pauses in their breathing, a choking noise, increased work of breathing, heavy breathing, mouth breathing, especially an obligate mouth breather, like during the school day, where they're always breathing through their mouth and it's kind of noticeable, that school daytime activity should be like, maybe they have a nighttime, maybe they have obstructive sleep apnea, and it should be evaluated further. Enuresis, restless sleep, excessive sweating, hyperextended neck and knees tucked under the body or other odd sleep positions. So a very common position is that the child will sleep kind of with their neck extended and their chin tipped up. And then another common way is they'll sleep with their bottom up in the air because they tuck their knees under them, and then they have their head lower than their bottom. And both of those positions are kind of their own discovery that those positions decrease their obstructive sleep apnea experience. And so they'll naturally trend towards those because it's better sleep. Similar to like TET spells and other pulmonary cardiac issues, like children will find, like if they're crouching in the floor oddly, then it's like, what are they trying to address with that behavior? And sometimes it's a physical thing like a heart problem or sleep apnea. So beyond odd sleeping positions, there's also frequent wake-ups during the night, dry mouth, poor school performance, aggressive behavior, hyperactivity, daytime sleepiness, morning headache, age-inappropriate napping, difficult to wake up, treatment-resistant depression, anxiety, or headaches. On physical exam, you should have increased suspicion if the child is obese or failure to thrive, if they have swollen and irritated mucous membranes from the barotrauma of overcoming obstructive events, irritated uvula. I have had patients present just because they went to the ER with an irritated uvula and their ER provider was like, I think this is from untreated sleep apnea, and it was. Deviated septum, adenoidal facies. So that is kind of that child that you can see quickly, even if you don't know the child, like, they don't seem well rested. They have the infraorbital darkening and elongated mid-faced mouth breathing. And that elongated mid-face actually changes in the bone structure to try, it's as a result of the obstructive sleep apnea that they're experiencing. It is actually making the sleep apnea even worse, but it's changing their bone structure and it changes their palate. Tonsillar hypertrophy, if they have a high arch palate, small lower jaw or a recessed jaw, which is like micrognathia or retrognathia. If they have a crowded oropharynx, a large tongue, microglossia, increased neck circumference, hypertension, or a loud P2 on cardiac exam, or swelling. So there's a lot of features, and this also speaks to why untreated sleep apnea has so many bad outcomes. For insurance purposes, usually what you just have to document is excessive daytime sleepiness, snoring, and witnessed apneas, but look beyond that. Also consider your special populations. So Down syndrome, trisomy 21, it's like 60% or more of folks with trisomy 21 have obstructive sleep apnea. They actually have a special FDA indication to do the Inspire therapy because it's so prevalent in that population. Folks with cerebral palsy, genetic disorders with retrognathia, microglossia, craniofacial changes, neuromuscular disorders, sickle cell anemia has increased risk of having obstructive sleep apnea, and obesity. So 5% of general population, but much higher in special populations. This is kind of a picture of the most common symptoms of sleep apnea while a child is asleep and while a child is awake. So some of those same things we talked about: mouth breathing, snoring, bedwetting, odd sleep positions, frequent infections, night terrors, teeth grinding, restless, or behavioral problems, ADHD, hyperactivity, growth issues, or learning disabilities. In-lab versus at-home testing. So this is something where not everyone will agree on the same perspective, but I have a very strong leaning towards at-home testing. So a PSG or polysomnogram in the lab is a traditional. It does have the advantage of including a full EEG and video. The disadvantages are expensive. It costs thousands of dollars. The start to end times are set by policy. It requires time off work and school. It may be more difficult to sleep in that environment. And I love this child here in the photo who's set up for his PSG. I'm going to do a sleep study. And I especially love his little hand because he has the O2 meter on his hand and that pulse oximeter. He's like so aware of it. He's, I'm guessing, watching a screen to help him be distracted as they get him set up, but he's still very, very aware of everything that's on him, even in a distracted state. The at-home testing is newer. It's not new. It's been around for a long time in other developed countries, newer in the United States. The advantage is more comfortable. It's more affordable. It costs usually $100 to $300 rather than a couple thousand. The schedule is flexible. It can fit in with the family and how they currently function. The disadvantage is it doesn't have an EEG and there's no video, and insurance navigation is still a bit tricky. Both types of tests can do detect apneas, diagnose OSA, look at oxygen saturation, flow, or peripheral arterial tone. They have a microphone. Both can have the option to include carbon dioxide monitoring and leg movements. So they share a lot in common, and I really think at-home testing is the direction we should be going now and where we'll be in the future. At-home testing, the two devices most relevant to children are the WatchPat, which is FDA approved for age down to 12. And I have used this for 12 and older on a number of occasions. And then the Knox T3, which is FDA approved for age 2 and older. And I have used this for children at home on fewer occasions. It's a little bit more challenging for a child. So if they qualify for the WatchPat based on age, I definitely do that. And then the Knox T3 if they're in that 2 to 11. So resources to get these at-home testings are still pretty limited. There are some online clinics that offer virtual appointments and mail the supplies to get tested, and then it's mailed back if it needs to be mailed back. In our local communities, it's something I've done and I'm interested in continuing to do. And then in Iowa, Dr. Alex Iannone, who's a wonderful pediatric sleep medicine doc and in charge of the sleep clinic there, is something I'm sure she'd be open to a conversation about. And I'll just go ahead and say that, and she can get back to me and say, hey, what did you do? And I'll say, yeah, I think we should talk about it. The American Academy of Pediatrics issued a practice guideline more than 10 years ago, back in 2012, stating that if PSG is not available, then alternative diagnostic testing can be considered. And then the American Academy of Sleep Medicine 6 years ago in 2017 said use of a home sleep apnea test is not recommended for the diagnosis of obstructive sleep apnea in children. The ultimate judgment regarding proprietary of any specific care must be made by the clinician in the light of the individual circumstances presented by the patient, available diagnostic tools, accessible treatment options, and resources. So pediatric inpatient sleep studies are very challenging. The AASM has not fully come aboard with home testing. I feel like they're kind of slow as an organization in multiple regards, and that's fine. They are looking at a lot of pieces, but they kind of keep the door open saying, treat the specific child. Very quickly, this is a PSG. And the main thing I wanted to point out is this is the first half of the night, and the child was having all these red dot lines are breathing problems. And then they got put on CPAP right here, and they went to a pressure of 4 and then to a pressure of 6, 5, and then 6. And all of their breathing events cleared up. Their oxygen looked wonderful. And they have this phenomenon that I see a lot called REM rebound. So you can tell in this pre-portion without CPAP on, this child had no REM sleep there, because REM sleep includes worse obstructive sleep apnea experience. So the brain often prioritizes staying out of REM. And then when the sleep apnea is treated, we usually see REM rebound, which is this long section of REM because the brain's like, oh, great, it's finally safe to experience REM. Let's try to catch up on the REM we've not had for the last 2 years. And that is part of why people's experiences, once they start CPAP, they feel a lot better. This is a 2-year-old child that's pre and post tonsillectomy. So most notably, you can see all these breathing events across the first night and these deep oxygen desaturations. This child was going below 70, like multiple times throughout the night. The child had a tonsillectomy because they, on clinical exam, seemed to be the primary issue. And this is their oxygen level post-test. It's beautiful. It's perfectly clean. They had a smidgen of breathing events when they were in REM, which again, we would expect to see. REM is more problematic, but those desaturations were very shallow. So this is a huge change for this child to go from this picture to this one. When you're thinking about guiding next steps, evaluate for a tonsillectomy and adenoidectomy. That's primary for all children. Now, if it's a teen who's adult-sized, obese, and doesn't have tonsillar tissue visible on exam, they probably don't need a TNA. They probably need CPAP, but definitely start by having the tonsils and adenoids assessed. CPAP is a good option. I think a lot of people are like, oh, there's no way a child would do CPAP, but truly a lot of them do just fine because they sleep better and they breathe better. You can use positional therapy if you have nothing else, so raising the head of the bed and trying to keep them off their back. And you can consider discussing weight change if there's a path forward that is helpful and not negative. I think a lot of times children are already hyper aware of their weight. And it's a really emotionally difficult topic for them. And if you just kind of say, well, you could lose weight without any support or emotional sensitivity, I mean, that's more harm than good in my mind, because obviously if they could just lose weight, that would have happened already if they're interested. So if you're going to suggest this as an option, it really needs to be partnered with sensitivity and a clear, supportive plan to move forward, not just, could you stop snacking? You know, like more than that. So to review a little bit again about the total sleep time and circadian rhythm, with that across the ages, we saw that babies have disrupted sleep, but some tendency towards nighttime sleep. Children sleep at night and should not be napping during the day. And then teens are delayed phase. For children in OSA, if what you can remember is that it's present, problematic, and treatable, that would be outstanding. There's a lot of details there to consider, but we need to start with awareness that it's an issue and that we can do something about it. And you can kind of see this child here is sleeping with his neck extended and his chin pointed up because he's trying to open up his airway while he's sleeping. Our last objective is to prescribe practical solutions for insomnia in kids who have autism spectrum disorder. So it's a significant issue. I get a lot of families who have children with autism, and sleep is a very problematic issue for family dynamics, for parent work schedules. It's a safety concern. If you think about a child who has significant autism and is not making safe choices, and then you have a period of time of like a couple hours at night when everyone else is asleep, totally unaware of what's going on with that child, and that child could be like in the kitchen, outside the house. Like I've had parents report so many concerning circumstances where they're like, I don't know what to do to keep my child safe. And I've had parents who say like, one of us are quit our job because we have to have someone awake pretty much around the clock because their sleep is so problematic and they're awake at all these weird times. I think in general, there's a lot of reason that sleep is worse in autism, but part of it is that sleepiness cues may be more difficult to appreciate or capitalize on. There's so much going on neurologically that those subtle cues might be missed, or some behavioral issue happens and then that sleep cue just kind of got blown out of the water. The ways I approach it are to screen for circadian phase shift, stimulus control, and medication. So children with autism are more likely to have a delayed circadian rhythm, as well as blunted or absent circadian rhythm of melatonin. So what is perceived as trouble falling asleep or insomnia may be a delayed phase without a strong sleepy cue until later than is preferred. So for example, a child may be asked to go to bed at 8 p.m. to get enough sleep before waking up at 6 a.m. for the morning routine and for school, but the child may not feel sleepy and may not fall asleep for 2 hours. That could be looked at as insomnia. However, if this same child may be allowed to fall asleep easily and sleep well if allowed to go to bed at midnight and get up at 10 a.m. So you do have to be cautious if there's a circadian aspect where the child actually can fall asleep and stay asleep just fine. They just need to be in their own window or have their window worked on. Behavioral interventions. So I always reinforce to parents, sleep hygiene is necessary, but not adequate. So it's not just like put away the screens. That's not the solution. But stimulus control, which is part of cognitive behavioral therapy for insomnia, extends well to children. Stimulus control is kind of like that. The oldest example in the book is that Pavlov dog. So bell rings, dog gets eats a treat, the dog salivates, and then you connect those, you keep connecting them. So specific. It's super weird. Why would a dog be hearing a bell? But it creates a strong connection over time that's unique to that circumstance. And then it's consistent. And over time, you can just ring the bell and the dog will start to salivate. So here, you want to find stimulus control for a child and their sleep. You want it to be specific to the child so it creates a strong connection and the child likes it. It has to be unique to bedtime because we really need to be a neuro-strong stimulus control. Kids with autism, they're not going to do something neuro-light. They need a neuro-strong stimulus. And it needs to be consistent every single night. So I love a plain small bedroom with just a bed or mattress on the floor, no toys or extra items in the room, maybe a few reasonable things like a few books, a sound machine, a projection light, comfort items like a picture of the family or a stuffed animal or a music box. Common things that work well for kids are something like the slumber pod, which it puts them like in a little cave, blackout curtains so we can just not get them exposed to light if at all possible because they need as much circadian help as possible. Weighted blankets are popular, but for those children who find them too hot, they can do the Huggaroo type bed sheet, which is thin but really tight. Audiobooks are a very popular one, and your child could listen to Charlotte's Web every night for the next year. And then as soon as they hear Charlotte's Web, their nervous system will start to calm down and get ready for bed. Super fuzzy sheets, light, and then the visual clocks to say, okay, it's 3 a.m. That's a red, don't get out. It's yellow, it's close to 7 o'clock, it's close to the time, and then green when it's 7 a.m. and okay to leave the room. So the child can just be more informed and more aware. Oh, it's not time, better keep resting. I don't feel tired, but better keep trying. Quickly, the prescribed medications. So I start with behavioral training, and if that doesn't work, I partner with a medication to reinforce the behavioral training, and then ideally can back off the medication, but sometimes need to stay with it. I think about 40% of children in research studies, looking at population studies, about 40% of children with autism are on a sleep aid. The prescribed ones to consider are trazodone, mirtazapine, doxepin, amitriptyline, hydroxyzine, ramelteon, clonidine, and guanfacine, and there's some dose ranges there. A common thing I've come to do over time is to flip-flop. So high level of autism, completely disrupted sleep, the child would be unsafe at night if they were awake. I'll say, okay, how about you do 2 weeks, but if they stay on the same sleep aid all the time, it wears off. So I'll say like do 2 weeks of trazodone followed by 2 weeks of doxepin and then switch back to trazodone. So they're going back and forth and that helps. So in review, we talked about circadian rhythm across the ages, how it's really different between a baby, a child, and a teen, how a pediatric OSA is present, problematic, and treatable, and then insomnia is an issue in children who have autism, and you need to partner together behavioral therapy, specifically sleep stimulus control, oftentimes with a prescription that stays or fades for best care. That is the end. I have some extra slides, but I can also do questions if anyone has questions.
Yes, we have a number of questions, so let's dive right in. There were a couple of people who asked about the name of the app that requires them to do a mission to disable the alarm.
So I have that. For teens, Alarmy is, I think Alarmy. Oops, sorry. Alarmy is here. It's like the second major bullet point down. It helps with heavy sleep inertia. So that's like doing math problems, jumping jacks, picture of a sink. But the nap is called Alarmy. It's alarm with a Y on the end. There are tons of these out there, so do be careful, because there's another one that's like called Wakey Wakey, and that is weird because it has a stranger call you through the app to wake you up in the morning. So like tell parents they can't just go with whatever. They need to supervise what their child is signing up for. But Alarmy is one, and there's a couple similar ones. And then Doze app, DOZE app, is intended for teenagers with insomnia, and that's the other app I really like quite a bit.
Right, thank you. In regards to the typical ages when discussing the circadian rhythm and sleep needed, how does a baby being born premature?
I love that question. So, yeah, if a baby is born premature, what is going on with their circadian rhythm? And they've done a number of studies on this. My favorite studies are when they look at premature babies who are in the NICU, because they can, I mean, that environment can be fairly well controlled. And so let's say a baby is born at 35 weeks or 34 weeks, and there's 6 weeks up until they would have been term, or 40 weeks. So when baby is 34 weeks, does the clock start ticking, and then by 6 weeks or 40 weeks, they're producing melatonin? Or is it adjusted for gestational age and they're not producing melatonin until 46 weeks? So for that baby, 12 weeks after they were born. And it turns out, even with light, like keeping the light down at night and bright during the day, newborns who are premature don't start that 6-week countdown to making melatonin until their 40-week expected due date. So you add 6 weeks on after they turn 40 weeks, gestational age, whether they're born 4, 6, 8, 10 weeks early.
Thank you. That was a great question. Should teens be allowed to nap?
So I think if that's a great question. If teens are napping because you're in this situation where they have delayed phase, but their school schedule or life schedule does not allow for them to get adequate sleep at night, and we can't change their schedule, and we can't do circadian shifting for them for whatever reasons, I do think it's better to have them nap than to be sleep deprived. I tell parents, if we worked through other things and it turns out that's the best solution at this moment in time for this particular child, my advice is that nap should be as early in the day as possible. So like, can they nap at 2 or 3 p.m. or 4 p.m.? But if at all possible, try not to be napping after 6 p.m. because that's just going to delay their falling asleep and extend their sleep latency to 3 a.m. instead of 2 a.m. So napping is okay, not ideal. And if it happens, put it towards the afternoon if at all possible.
Great. When do you expect the adolescent delayed sleep phase to switch to adult phase?
That's another great question. So it's not 18. That is like an arbitrary adult number we've picked out. I would say it's somewhere between 20 and 25. Usually by 25 years old, I expect them to be kind of at their adult sleep brain. And then some get there sooner and they're there more or less by 20. Others really need that delayed phase up until 25.
Thank you. Are schools recognizing teens' natural delay in sleep rhythm and adjusting school start times?
I do love that question because it talks to like, how do we make this work for our community? Some communities are doing that, and it has happened after a lot of parent advocacy or team member advocacy. So in Iowa City, where I was practicing previously and did my training, there was a lot of advocacy in that town, and they were able to delay start times for teenagers, which is awesome. I will say I've noticed in this community, I have teens on the bus at a range of like 6:30 to 7:30 in the morning. And so it's super early and I just kind of cringe. I'm like, oh, that poor teen, they're still like needing a whole sleep cycle. But in communities that have advocated for it, yes. In communities that have not, no, the teens are just forced onto whatever schedule is most convenient for everybody else.
What is your input on the effect of the circadian rhythm, REM sleep, on consistent bedwetting?
Can you say that one again?
What is your input on the effect of the circadian rhythm / REM sleep on consistent bedwetting?
So I do think there is a connection. There's within the nighttime sleep and within non-REM versus REM sleep, there's a lot of different things happening with the body. And I tend to see, I don't think we have enough like concrete information from research studies to clearly say it's one or the other, but I tend to see there be an association with more bedwetting with non-REM sleep and less bedwetting if they're getting adequate REM sleep. And why they may not be getting adequate REM sleep is several things. That the child has insomnia and they're a restless sleeper and they're popping out of their sleep stages. If there's an environmental issue, if they have untreated obstructive sleep apnea, if they're on a medication that is changing their sleep architecture. So I do look at that when a child presents with enuresis. I try to evaluate, are they non-REM sleep heavy or and REM insufficient?
Thank you. How long are children usually prescribed sleep aids for? Are there concerns about teens just stopping a sleep aid due to risks of withdrawal or side effects if stopped abruptly?
Another great question. So I would love it. Just as a side, I'm going to play, this is active sleep in a baby, which is more like REM, and then I'll play the non-REM so you can kind of see the difference as I'm chatting away. I would love to say that, we get kids started with a behavioral program and stimulus control, partner with a medicine short term when needed, and then they're back off of it. But to be honest, I see a lot of kids who are on sleep aids for years, like from 8 years old to 18 years old or beyond. So I do think that they end up being on it for a long time. I am concerned. I think any substance has the potential for negative outcomes. So that is a concern. However, I usually acquiesce to long-term sleep aid use when it's a safety concern, when it's so impactful to their day. When a child is not taking medication reliably, I do, whether they're teens or just like angst, like children who don't cooperate at all times, I do avoid a couple of sleep aids. I especially avoid clonidine. Probably that'd be the number one that I avoid is clonidine. And then to some extent, I probably avoid guanfacine. But clonidine is really the one to avoid if you have intermittent use.
Great, thank you. In children with untreated OSA, refuses to wear CPAP, parents hesitant for surgery, can sleep aid medications be utilized to help with sleep initiation and sleep maintenance? If so, which sleep aid meds would be the safest option?
So that is a really good question. A child who has untreated sleep apnea will probably have more disrupted sleep. There have been studies on medications that impact sleep with untreated obstructive sleep apnea. I don't know of pediatric studies, but I will say in the adult studies, I think the expectation would be like, oh, if they're on Ambien and they have untreated sleep apnea, like, wow, could they like have some major negative consequence? And the studies don't show that they do, essentially. And then actually there are some medications that people take before bed that seem to increase the tone of the muscle. So it actually makes sleep apnea a little bit better, which is kind of crazy because it impacts muscle tone. On the whole, if a child has untreated sleep apnea, they're not cooperative with obstructive sleep apnea treatment via CPAP, or they're hesitant to do a tonsillectomy and adenoidectomy, or it wouldn't solve the problem, I would still be okay with a sleep aid. I would go for the lightest one possible, and probably trazodone, because it's one of the ones to show that it actually probably increases muscle tone a little bit. I would avoid anything heavy. I mean, we don't really do heavy stuff for children anyway, but like to me, common sense just means like, or common sense would just say like, don't do a heavy sleep aid with untreated sleep apnea. And then I would also talk to them about positional therapy. So getting them the head of the bed raised. So like if this is a bed, you can put books under the top of the bed so it's at slant, so the whole bed is slanted. And that's not, it's not difficult to find something at home already that you could put under there, like if it's books or boxes or a brick or a cement block. They can also do wedge pillows that start at the waist, and there is a wedge pillow called Medcline that starts at the waist, gives the head a rise, and is meant for side sleeping. So it has a pocket for the shoulder to fall down into and a body pillow around it. So it really firmly keeps people on their side in a positive way. There are other sleep position aids that keep people on their side in a negative way because they get a consequence if they roll to their back. But I think it's better to do a positive. So like a comfy pillow.
All right, thank you. And thanks for all the great questions submitted. We weren't able to get to all of those, but Dr. Immen, if you want to take a look, you can address some of the questions that were left unanswered. So
great, thank you.
Yeah, thank you. So now we'll transition